Florian Wagenlehner, who's a professor of urology from Justus Liebig University in Germany. Florian's been spearheading a number of global studies into the prevalence of infection. He's also spanned the spectrum from basic science to clinical, really heading up a lot of the work on resistance. I don't think there's yet an FBI for bacteria yet, but if there was, I think Florian would probably be a member of that.
Well, thank you very much for this nice introduction. It's a real privilege to be invited here, and I'm giving a bit of an evidence on the epidemiology and risk stratification of urosepsis after TRUS biopsy of the prostate. So we all know that biopsy of the prostate is an inherent procedure in the diagnostic management of prostate cancer. So it's the golden standard, and we accepted for a long time that some low rates of infectious complications, around 1%, were applicable to this diagnostic procedure. But in the recent years, starting from 2001, 2002, this is one study from Canada in more than 70,000 patients, it came up that the infectious complications went up to around 4-5%, although the number of prostate biopsies did not increase in these years. Now, it's debatable if this is a large number, or if this is still an acceptable number, but if we see that study also, they mentioned that 30-day mortality after the diagnostic procedure of transrectal prostate biopsy was 1 in 1,000 patients. So in a diagnostic procedure, mortality does apparently exist. And if we do extrapolate that, and we approximately perform 1 million prostate biopsies in Europe per year, the same is probably performed in Northern America, then we end up with a significant clinical problem. Further studies, retrospectively mainly, have been performed in the US SEER Medicare database, and they more or less found the same amount of infectious complications. They compared it to a control, and they looked specifically at the rehospitalization, and they found that 7% of patients after prostate biopsy were rehospitalized. And there was another study in the European screening study for prostate cancer. They prospectively looked at this, and they also found 4.2% febrile episodes after transrectal prostate biopsy. Now, we looked at that also in our European section of infection in urology, a full section of the ESIU, and we performed a prospective study, which is a side study to the global prevalence study of infections in urology, which is taking part every November since 2003. And this side study started in 2010. And in these 4 years, we were able to recruit more than 1,200 patients. The design is depicted here. Within 2 weeks, each department taking part in the GPIU study is able to include also patients for the prostate biopsy site study, and then those patients are followed up for a further 2 weeks. And I must admit that we have 4 continents and 136 centers in this study. And these are the results. Worldwide, transrectal prostate biopsy is performed still in 97%, so it's still the golden standard in diagnosing prostate cancer. Almost all of these patients got antibiotic prophylaxis, as it is recommended, and fluoroquinolones-based prophylaxis, either alone or in combination, was given in 80%. So it was a little less in the last 2 years than compared to 2010 and 2011. Now, again, the complication rate here, symptomatic UTI, 5%. The majority of pathogens are Enterobacteria, E. coli, but also other Enterobacteria, Klebsiella. We also see Enterococcus and Pseudomonas, but Enterobacteria are the major pathogens that were cultured, but only in 50%. In the other 50% of patients having symptomatic UTI, there were no pathogens cultured. And febrile UTI was seen in 3%, and all these patients had to be re-hospitalized. In this study, also risk factors were alluded to, and none of the risk factors looked for were significant in the multivariate analysis. Preoperative bacteria were looked at, bowel preparation, if it was performed or not performed, if antibiotic prophylaxis was given longer than 1 day or only 1 day, if fluoroquinolones were in the prophylaxis, if it was a repeated biopsy, if local anesthesia was given. The number, of course, was the only one that was statistically significant, but paradoxically, it was In those who did not have symptomatic UTI, the number, of course, were even higher. So number, of course, apparently is not a risk factor. And histopathological inflammation, at least in this study, was also not a significant risk factor. What was popping up in that study is that only in 20% of patients a urine culture test was performed prior to performing biopsy. So that is a constant question: is bacteriuria, asymptomatic bacteriuria, a risk factor or not? It's debatable. There is a study from France, from Frank Brier, who looked specifically at bacteriuria in prostate biopsy and did not find that bacteriuria was a risk factor for post-biopsy infection. So those who had a bacteriuria prior to biopsy did not develop prostatitis, did not develop bacteriuria after the biopsy, whereas there were some who had pre-biopsy no bacteriuria who developed bacteriuria after the biopsy. There was no correlation, so apparently it's not a risk factor, at least in that study. What are other studies looking for? There's a large study from France, the Prosbiotate study, that has just been published in the Journal of Urology. So they looked at patients in France over 2 months, and they included 2,700 patients, and they all received transrectal prostate biopsy, and they recommended fluoroquinolones as prophylaxis. And in their study, urosepsis was found in 2.8%. Again, only in 50% bacteria were grown, either in urine or in the blood culture. And again, enterobacteria were by far the most frequent bacteria found. They found risk factors, which was history of prostatitis in the history, and use of fluoroquinolones in the previous 6 months. And then they looked also at the sepsis episodes, and interestingly, they looked at the first antibiotic that have been given for the patients that have been readmitted for sepsis. So remember, all the patients had by definition fluoroquinolones given. Only if they were allergic to them, they were able to take other medications. But in the patients having sepsis, still 30% received fluoroquinolone in the first instance. So that's certainly something that should not be happen, because you should suspect that the bacteria would be resistant to the prophylactic agent. And this is just a case we have seen a couple of years ago. There was a patient that was biopsied outside in a private urological practice, and then was admitted with sepsis. Was a multimorbid patient, and the doctor on call, despite the fact that the patient received ciprofloxacin as the prophylaxis, gave levofloxacin as a treatment for the sepsis, which is, of course, wrong, because there is 100% cross-resistance, and the urine cultured multi-resistant fluoroquinolone, resistant against fluoroquinolones, as well as cotrimoxazole. And these are the multiple mistakes that can ultimately lead to a fatal outcome. And that was, unfortunately, the outcome of this patient. And I show this picture because, as you see here, this is the rectal mucosa, and this is where the prostate is and where the biopsy is taken. And this is probably what is not visualized too often, but we do perform some hematoma, probably by doing the biopsies. And hematoma, blood and bacteria, they go along very well with each other. So that is something we have to keep in mind if we also discuss possible treatments or possible prophylaxis for these patients. So what other cohorts might be at risk? This is a recent study that especially looked at patients under active surveillance. So patients with prostate cancer that are not operated, and by the protocol, they undergo prostate biopsies every 6 months or every year. And you see here, the more biopsies they had previously, the higher is the risk that they will develop febrile infectious complications. If they had 4 to 5 biopsies prior, this goes up to 16%. So that is certainly something very high, and it's a problem, because active surveillance now is something that is coming up, but with 15 to 16% risk of febrile infectious complications, we might run into problems. So a summary of general risk factors. Some of them have been seen in other studies, some of them have not been seen in other studies, is seen here. So high comorbidity is a risk factor. Some studies have shown that a badly controlled diabetes mellitus is a risk factor. Enlarged prostate in some studies, in others not. Untreated bacteriuria, as I've shown you, in some studies it has not been shown to be a risk factor. Urogenital infection history, especially prostatitis, has been shown in one study, or at least in one study, to be a risk factor. Indwelling catheter might be a risk factor. Bladder stones. And antibiotic treatment, especially fluoroquinolone treatment, at least in the last 6 months, probably in the last 12 months, or certainly is a risk factor. And travel to high fluoroquinolone resistance countries has also been demonstrated to be a risk factor because these resistant bacteria are taken up by alimentation, by food, and for example, if somebody comes back from Asia, from South Europe, where fluoroquinolone resistance rates might rise up to 70%, so that is something that can be asked in the history. But in my view, it is not, it's not definitely the highest risk factor is probably, in my view, the fluoroquinolone-resistant E. coli in the fecal flora. And that is also nicely shown in this study, and it also fits into the parallel increase of the infectious complications with the parallel increase of the fluoroquinolone resistance. So in that study by Stainsel, they elegantly showed, because they swabbed, they performed rectal swabbing in all the patients, and then they looked for the fluoroquinolone susceptibility or resistance in those rectal swabs, and all the patients received fluoroquinolone prophylaxis. And then they looked at the infectious complications. And you see here, around 25% of the patients undergoing prostate biopsy had fluoroquinolone-resistant bacteria in the rectal flora. They all received fluoroquinolones, and only those patients who had fluoroquinolone-resistant bacteria, they developed infectious complications such as prostatitis, sepsis, epididymitis. The others did not develop infectious complications. So that is probably the proof that fluoroquinolone-resistant bacteria might be at least one of the most important risk factors. So we need strategies to prevent these infectious complications because they might rise with the increase of fluoroquinolone resistance. And certainly one is to prove the indication for prostate biopsy, and this is something that has also arisen from this discussion on the infectious complications. We know that it's in the guidelines, not only one PSA elevation should be biopsied. We should consider if the patient, if there is any information coming out, if the patient is multimorbid, if he's elderly. So that, I think, is something that's stimulated by this discussion, that the indication for prostate biopsy is now taken more seriously. And then we should ask for risk factors that might select for patients that have fluoroquinolone risk, fluoroquinolone-resistant pathogens in the fecal flora. And as I've said, the antibiotic history is important. So if they had fluoroquinolones in the last 12 months for either infection or prophylaxis, that is a candidate that is at high risk having fluoroquinolone-resistant pathogens, and if there is a travel history to high-resistance countries. So if we define the patient that has a high risk, so what alternative antibiotics can we recommend? And that is problematic, because this is the evidence which we are working upon. Why are we giving antibiotics for antibiotic prophylaxis for prostate biopsy? And this is the meta-analysis by Sani. So as you see here, most studies have been performed in the year 2000 with fluoroquinolones. There is one study that has been performed for sulfonamides, low patient numbers, randomized study, and there are 3 small studies that have been performed with gentamicin, each 10 patients, carbonicillin, each 20 patients, and piperacillin, again, each 20 patients. So this is the evidence we rely on if we talk about alternative antibiotics. And this is, for example, the AOA best practice statement from 2011. They recommended in the second alternative row aminoglycoside plus an anaerobic active agent. So there is no real evidence either for the aminoglycoside, and I will give you some pharmacokinetic data later on, as well as the anaerobics, because it's not recommended in the first line. Why should it be recommended in the second line? So therefore, we have to discuss several aspects if we talk about alternative antibiotics. So one is clinical studies. There are more and more clinical studies coming up, and most of them, almost all of them, are not controlled studies. And these are studies that are now taking up multiple antibiotic agents, even up to last resort agents. So we don't want that, because that is totally in contrast to our antimicrobial stewardship, what we would like to do. Therefore, these studies, which are not comparative, do not help us very much. So pathogens, bacterial spectrum, is certainly important, and I will talk shortly about pharmacokinetics. So expected pathogens, I've showed you in the studies that by far the most important are enterobacteria, and we've now seen by Matt that even certain strains from E. coli probably are more prevalent, such as the ST131 strain. And then in the second line, Enterococci and Pseudomonas. There are almost no data on anaerobic bacteria, only some case reports, so I doubt that anaerobic bacteria are important in transrectal prostate biopsy. What about pharmacokinetics? Does the antibiotic need to be concentrated in the prostate tissue? As in most prophylaxis, it's rather, the data are rather scarce. This is a study from 15 years ago, which is good because it compared ciprofloxacin, fluoroquinolone versus gentamicin, and at that year, or at that time, the resistance was low. So therefore, this is more or less the natural history with these two antibiotics. And it also compares an antibiotic that has a rather good penetration in the prostate with an antibiotic, gentamicin, that has a rather poor penetration into the prostate, which is shown here. So fluoroquinolone has a very high concentration, whereas the gentamicin has a low one. Gentamicin aminoglycosides are mainly concentrating highly in the blood. So it's the question is, do you need high concentration in the blood, or do you need high concentration in the prostate? And they also drew, after 2 hours after the prostate biopsy, they drew blood cultures, and thereby they were able to assess bacteremia, silent bacteremia, which is frequent. So, but that was statistically significantly higher in the gentamicin group compared to the fluoroquinolone one. And the symptomatic bacteremia, accompanied with fever or shivering, was absent, practically absent in the fluoroquinolone group, whereas it was 22% in the gentamicin group. And that is a nice study because it's, I think, the only study that associated pharmacokinetic parameters with prostate biopsy prophylaxis. So at least it shows that probably we do need antibiotics that also have a concentration in the prostate tissue or in the prostate fluid. And if we summarize the antibiotic substances that we can or potentially could use for prophylaxis, then we see the fluoroquinolones by far have the highest capability of pharmacokinetic penetration in the prostate. Trimethylprimsulfamethoxazole also has some concentration, but it's lower. Unfortunately, there are no data at all on tetracyclines. It would be a nice substance group probably, but we probably should study that. Beta-lactams, recently there are some studies from Japan that looked at carbapenems, though carbapenems apparently do penetrate quite well, also in the uninflamed prostate, but it's a last resort antibiotic, so I don't think we should really use a last resort antibiotic in the prostate biopsy prophylaxis. Aminoglycosides do not have concentration, and fosfomycin is another antibiotic that could potentially also, there is some pharmacokinetic studies that could potentially be used in the prostate biopsy. And this is a study, a clinical study from Turkey that it's an open study, but it compared fluoroquinolones versus fosfomycin. And they showed a lower rate of febrile complications in the fosfomycin group, but it was not statistically significant because probably numbers were still too low. What about rectal swabbing? This is a study from Tony Schaffer. They looked at rectal swabbing. So is it better to test the bacteria instead of empirically giving a antibiotic? And they looked at that with selective agars. So fluoroquinolone was in the agar if bacteria were not growing, then there was no fluoroquinolone-resistant bacteria present. If bacteria were growing on the selective agar, then a fluoroquinolone-resistant bacterium was present. And it was also an open study, not randomized, so only 25% of the patients received rectal swabbing. But when they found resistant bacteria, then they gave antibiotic prophylaxis according to susceptibility testing, and none of those patients developed infectious complications, and that was even cost-effective because the sepsis here in the 2.6% was very expensive. So it is even cost-effective, and number needed to treat was 38 men. So we tried to group that into an algorithm. Of course, you should look if prostate biopsy is indicated. So if it's indicated, history might do a trick. So if the patient had received fluoroquinolones, if he traveled to large resistance countries, so he might be at risk for fluoroquinolone-resistant bacteria, and if feasible, microbiology is probably a good thing to do. So if he does not have risks, then fluoroquinolones could be given. If he has a risk, alternative antibiotics should be given. But it's still a problem which alternative antibiotics, and the guidelines certainly do not apply for all countries. For example, here in this study, in biopsy from Italy, 60% of the patients had ESBL bacteria and 70% fluoroquinolone-resistant bacteria. So if you recommend cephalosporins, they would certainly not do the job in this region. What about non-antibiotic prophylaxis? One study that looked at Povidone-Iodine, randomized study from Canada, very well performed study. They were able to decrease the infectious complications. Unfortunately, it was not statistically significant because you probably need a lot of patients to demonstrate an effect. It was effective, but not statistically significant. But there is a meta-analysis where it was looked at. Povidone-iodine apparently did better, plus antibiotic did better than antibiotics alone. So this is one strategy. And of course, there was a question before, is there another possibility? Of course, we run now into the perineal biopsy with the new techniques, MRI, fused sonographic techniques. So that is what we currently use in Gießen. Thereby, you don't penetrate the rectal flora. And there is also a systematic review on that who looked at 6,600 patients who have been biopsied perineally. And the infectious complication rate reported altogether in these studies was rather low, or less than 1 in 1,000 patients. So perineal biopsy might be something that is more safer than transrectal prostate biopsy. So in conclusion, I've showed you that we have a clinically significant increase. There is also in the large studies a mortality could be demonstrated. And probably fluoroquinolone-resistant bacteria is the primary risk factor for the infectious complications, and I discussed with you some strategies to reduce the infectious complications, but the ideal antibiotic is not studied yet because we do lack a lot of data on pharmacokinetics of suitable antibiotics such as tetracyclines, for example. Thank you very much.
Just a question relating to the transperineal biopsy. I liked the algorithm you showed in terms of risk stratifying. Do you think there should be another box in there saying that rather than trying to change the antibiotic or find an antibiotic, because it looks like the options are limited. We've used the perfect antibiotic. The quinolones were the perfect antibiotic, and we've used them up. Anything else doesn't look like it's going to be as good either due to penetration or resistance characteristics. Do you think it should really, that yes box should actually be going to transperineal biopsy?
You mean here?
Yes.
Yes. Probably.
And just one question to the audience. Who at the moment is risk stratifying their trust biopsies? Just two hands.
Okay, any questions from the audience for Florian? Yes.
Regarding the timing of quinolone-based prophylaxis, in your practice, when do you give the first dose of antibiotic?
We give only a one single-shot antibiotic dose, and that is also shown in numerous studies that prolonged antibiotic use or as a prophylaxis is not better than a single dose. And we did a study where we looked at the selection property of a single dose of ciprofloxacin 500 milligrams, and that was already, if you give a single dose, you select for resistant organisms, and you probably, if you start that longer days before, then the selection property is even higher. So I think it's even a disadvantage to give a prolonged course of antibiotics.
There's a microphone, Andrew, just because it's the audience behind you.
See it. Sorry. Andy Doval from Cambridge. If you were to do rectal swabs on everybody, how long before you get the result?
Well, it's a culture issue, and you would have to do that 3 days before, because you have to at least probably longer, because if you grow resistant organisms, that is on the next day. You see on the selective agar that you have the resistant organisms, and then you should test those. So it probably you have to call them in 3 to 5 days before having the biopsy scheduled.
Because our trouble in the UK, as you probably know, is we live in a target world, and people get referred quickly on one PSA because everyone said, "Oh, we're running out of time already." So that again would delay things. But I think you're right. I think that's what we need to do. We need to try and convince the politicians that targets for prostate biopsy could be expensive and cost lives. So I think we need to try and, for some people it's really important to be diagnosed early, but for the vast majority it's not. And I think that's probably evidence like you've shown would be very poignant, I think, to show the harm that can be done by it.
Okay.